Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks if I can analyze a case study on Obsessive-Compulsive Disorder, or OCD. So this is differentiated, of course, from the personality disorder, Obsessive-Compulsive Personality Disorder. I'm talking about OCD here, not OCPD. Now, a case study is when a clinician wants to create a report on their interaction with a client, with the client's consent, of course, and it's usually done for educational purposes. A case study is sometimes referred to as a case analysis, a presentation analysis, or a clinical vignette, but all those terms essentially mean the same thing. The information is changed in the report, in the actual case study write-up, but in theory, the clinical essence remains the same. So OCD is a disorder that features both obsessions and compulsions. Obsessions are thoughts of fear or anxiety that push people to engage in rituals. When somebody does this, when they engage in the behavior to satisfy the fear or anxiety, that's referred to as a compulsion. Now, some people with OCD only have obsessions. Sometimes this is called pure O, purely obsessional OCD. They don't act on them, so they don't really have a compulsion part. But the reverse really doesn't happen, like compulsions occurring without obsessions. It's hard to imagine somebody having OCD with only compulsions. There are different expressions of OCD symptoms. For example, there is compulsive checking, concerns about contamination, and existential obsessions. So just to expand on the one example of compulsive checking, somebody with this particular expression might repeatedly check light switches, controls on appliances like an oven or a toaster, or they might check door locks repeatedly. If they don't repeatedly check these items, they get extreme anxiety and worry about what might happen because of their failure to check. Lamps or appliances may catch fire if they're not turned off, or if doors aren't locked, somebody could come right into a home or a residence and steal things, or they might get into a car and drive away with it. Now, insight isn't necessarily compromised when working with people with OCD. The majority of people that have the disorder realize that the obsessive thoughts and compulsive behaviors are not logical and that they are extreme in nature. The awareness and insight can be helpful, but often it still doesn't allow people to control the symptoms. OCD has real consequences for people, causes a lot of suffering. As many as 60% of those with OCD have depressive symptoms as well. Many have comorbid Major Depressive Disorder. And the combination of these two disorders has a major effect on the quality of life. We also see that 40% of people with OCD are underemployed or unemployed. 60% don't achieve what they want academically because of these symptoms. And 70% have difficulties with family relationships. This case study is focused on a presentation of comorbid OCD and depression, and I'll put the reference to this case study in the description for this video. Now, again, we're looking at comorbid OCD and depression, and specifically here we're looking at a case where depressive symptoms are thought of as being caused by the OCD symptoms, like somebody's depressed because they can't get relief from the obsessions and compulsions. Not all cases of comorbid OCD and depression can be thought of this way. In terms of treating OCD with comorbid depression, the most popular approach is cognitive behavior therapy, otherwise known as CBT. But in this case study, another method based on systemic thinking was used. This is an unusual approach for treating OCD, and it's one of the reasons this is such an interesting case study. Typically, counselors or other related psychotherapists don't deviate too much from CBT or something similar, like behavior therapy, unless another clinician has already tried those therapies and they have not been successful, which is what happened with this case. This unusual therapeutic approach, which seems to be inspired by strategic therapy, focuses on the depression instead of the OCD, and it involves a few steps. Encouraging the client to accept that OCD is a permanent condition. For example, if somebody's lost the use of one of their hands permanently, they can certainly adapt, but they're not going to have the use of that hand anymore. So acceptance can be helpful in facilitating adaptive behavior. Another step would be encouraging the client to focus on the depressive symptoms. I mentioned that before. We see blocking all attempts to discuss the OCD. This one, of course, is a little controversial. We see looking at the depression as caused by a failure of the client to keep promises that they made to themselves, helping the client create a self-promise list while suggesting that when the promises are kept, this will increase their self-confidence, and recognizing when the promises are kept. So congratulating the client when the client is successful. So now moving on to the details of this particular case study. The client in this case study was a 32-year-old restaurant worker. I'll refer to him as Stephen. When the clinician was first scheduled to see Stephen, the clinician noticed that it was 15 minutes past the appointment time, so he went outside and noticed a young man walking around an old Buick sedan, laying his hands on top of the car and saying the words, "door locked," over and over. The clinician was just standing there, and Stephen told the clinician that he would come inside in a moment. He was almost through. 10 minutes later, he came into the office. Now, this is interesting because right here, there could be a tricky situation. A new clinician might have had trouble with this part. It was good that the clinician did not walk up to Stephen and say, "Hey, are you Stephen," whatever his last name would be, because that would be identifying the client by name. And the clinician did not know for certain that the man standing next to the Buick was in fact his client. So the default position in terms of the counselor-client relationship would be that the counselor can't confirm or deny even the existence of the client. Now, of course, many clients sign releases, so the counselors can talk to different people. But again, when starting out, the default position, the counselor needs to be careful with this confidentiality. So I thought that was a good way to handle this, just walking up and not saying anything, allowing the client to say something first. Now, Stephen reported that his symptoms started at age 15. He would wake up in the middle of the night and make sure that the stove burners were not on. This behavior is something I've seen many times when working with people with OCD. Eventually, this behavior expanded so that he was spending 2 hours every night checking the stove burners and also checking the electrical outlets to make sure that they were not burning. It's easy to see how the symptoms can become extremely disruptive very quickly. At age 18, Stephen's behavior had become so disruptive that his mother took him to see a psychiatrist. That's when he received the diagnosis of OCD. He was also given several psychotropic medications, and he was sent to see a mental health clinician for weekly sessions of CBT. This is also pretty common when working with individuals with OCD. This idea that they would be treated by both a counselor or a related professional and a psychiatrist. By the time Stephen was seeing the clinician who wrote this case report, which of course was 14 years after the diagnosis, his medication had been changed 7 times, and he had been to see 7 different psychotherapists. Despite the efforts of all these different clinicians, Stephen's symptoms became worse. He demonstrated a genuine sense of frustration and hopelessness when he presented to this clinician. As I mentioned before, Stephen worked in a restaurant. His main job was to make the dough for bread. And when he was working with the dough, he would constantly worry that he had dropped something like his watch in the dough or something else that might cause harm to somebody. So he would tear the dough apart and look for whatever items he thought might be in there and then push the dough back together and put it in the oven. But this tearing apart and pushing it back together cycle would occur many times, so he would check it many times. When he was done work, he would walk back and forth between the restaurant and his car somewhere between 25 and 50 times to make sure that he actually clocked out. So he had like a time card and would clock in and out. He just wanted to make sure that he was clocked out. After this, he would walk around his car for about a half hour, trying to make sure that no one had broken into it. So this is when he was still at the restaurant trying to leave work. When he would get home, he would check his car for another hour to make sure that the doors were locked. Once in the house, he would crawl around on the floor for 1 or 2 more hours, checking electrical outlets for any burning smell. Stephen only brushed his teeth once a week because it took 2 hours. He was always worried that he missed a spot. So he would brush his teeth essentially over and over and over for these 2 hours, just trying to make sure he got every single part of his teeth. Now, one of the interesting things about Stephen's manifestations of OCD symptoms is that much of the time he kept engaging in this compulsive behavior until somebody commanded him to stop. The manager and his other coworkers at the restaurant would tell him to stop checking his time card. They would make him get in his car and drive home after work. When he got home and he was checking the door locks of his car, his mother would insist he he'd come into the house. When he was on the floor, smelling the electrical outlets, his mother would tell him to go to bed. Stephen looked at his coworkers and his mother's behavior as helpful. He recognized that their behavior was preventing him from engaging in the compulsions for even longer. The reason he was coming back into therapy was because he had a reason to believe that the manager of the restaurant was going to be transferred, and he was worried that the new manager might not be as understanding about his OCD symptoms. Stephen reported feelings of depression that he believed were caused by the OCD symptoms. There were so many things that he wanted to accomplish that he couldn't because of the constant obsessions and compulsions. The clinician recognized a few things after the first 6 sessions of listening to Stephen talk about the effects of OCD. He realized that they had a good therapeutic relationship, Stephen was motivated, and even though Stephen was discouraged about having OCD, he generally did whatever the therapist asked him to do. Like his past psychotherapist, he was compliant, which isn't really surprising given his behavior in these relationships with his coworkers and with his mother. The clinician also came up with a theory that is essentially the same thing as secondary gain. Stephen was reinforced by his coworkers and his mother because he had OCD. So because of OCD, people were interested in helping him. They had sympathy for him. In a sense, the OCD had become part of his identity as well as a route to getting attention that he craved. So in this case, there was too much focus on the diagnosis itself. At the start of session 7, the clinician told Stephen that it was unlikely that anything could be done to get rid of the OCD symptoms. He indicated it was probably a permanent condition, but Stephen could learn to accept it and adapt to it. Stephen looked at him and was clearly shocked, but then indicated that he believed that what the clinician said was probably true. The clinician went on to tell Stephen that it was the depression and not the OCD that was really preventing Stephen from functioning at a higher level. So if Stephen could get rid of the depression, he could see a lot of improvement even though he would still have OCD. Then the clinician moved into this whole idea of what causes depression, using an unusual theory that some depression is caused because people make promises to themselves that they don't keep. This theory goes on to say that the reason that people don't keep the promises is because the promises were made to satisfy somebody else, like the person's parents or other family members. People only keep promises that they are personally invested in. And if they keep those promises, it may increase self-esteem and in theory could lower feelings of depression. Now what's interesting here is that there's not much reason to believe this theory is true, right? It clearly ignores a lot of what we know about the causes of depression, and it doesn't really capture the mechanics of depression very well at all. Now it does make sense that these promises that people make and then don't keep could have some effect on their mood, and that's what the clinician was really latching on to in this instance. Now Stephen really liked this theory. He felt like he was always making promises for other people he wasn't keeping. He told himself he should be doing something to improve his life, that he would follow through with that action, but then he wouldn't do it and he would feel badly. So this theory really connected with Stephen's experience, and that's really an important element of counseling. The client here is really buying into the mechanism of change. So the clinician worked with Stephen to build a list of promises. Some of the promises were designed to be very easy to keep, like walking a pet or combing his hair, and other promises were a lot more difficult, like completing a resume or washing his car. So Stephen started on his way to keeping these promises. When he kept a promise, the clinician would congratulate him sincerely. Stephen started keeping a lot of the promises. By the 15th session, Stephen told the clinician that the last time he brushed his teeth, it only took him a half hour, and he's been spending less time checking his car when he gets out of it. Now the clinician told Stephen at this point that he really didn't care about what was going on with the OCD. He wanted to focus on the depression. So he asked him how things were going with the depression. This is an interesting move. The clinician here was really sticking with the plan, even though most clinicians would have told Stephen how impressive those accomplishments were. So he was kind of committed to this whole theory of really not worrying about the OCD and only looking at the depression side. The clinician just kept redirecting Stephen's discussions of OCD back to depression. Over and over, this happened throughout therapy. Eventually, Stephen kept all the promises he made to himself, like writing the resume and washing the car, and he reduced the amount of time he spent engaging in compulsions drastically. Compulsions that would go on for hours were only taking 5 or 10 minutes. After this, the clinician and Stephen decided to terminate therapy. The clinician followed up 3 months later, and Stephen reported that he was not depressed and he was getting things done. So after reading this case, it seems pretty clear why the clinician decided to make this into a case study. This is exactly the kind of case where a clinician would want to do that. Here's a client who had been to many clinicians before, and the symptoms only became worse. The client sees a new clinician who does something completely different, and we see a much different result. Now, the clinician had a few different theories about why he was so successful in treating Stephen. The clinician congratulated every promise that was kept, so this reinforced a positive behavior. Stephen started to trust himself, and he became more confident as he completed more of these tasks. One theory of OCD is that people who have this disorder don't trust their memories. So as they accomplish different tasks, where it's clear that they did remember something correctly, they start to trust themselves and their memories. And the last theory as to why he was successful is that all of these assignments were distracting. So essentially, they took energy away from investing in the OCD. It's interesting here that all three of these mechanisms are actually part of behavior therapy. So the clinician had an interest in this whole idea of keeping promises that a person was committed to, but that technique really came down to behavioral therapy, something the clinician acknowledged in his case report, which I thought was insightful. As I was reading this report, I was thinking about this behavioral therapy aspect, how everything seemed to be connected to it, and I was wondering if the clinician would recognize that, and he did. He made that connection as well. I find this connection to behavioral therapy with a lot of different strategies, techniques, and mechanisms in counseling. We see all these different types of names for counseling modalities, but a lot of it really does come down to behavioral strategies. So what are my thoughts on what led to the improvement in this case? Well, I'm not in as good a position as the clinician who wrote the report to speculate about the outcome, but my theory would be that the clinician helped Stephen to learn to command himself. So the only thing that worked for Stephen in his whole history with OCD was when other people told him to stop engaging in the compulsions. So essentially, he learned to direct himself, to become less reliant on other people, and to break free of the compulsive behaviors. So what are the ethics with this type of treatment? Well, the clinician who wrote this report did address a number of the ethical concerns with this particular course of treatment, including the idea that empirically based treatment like CBT should be used before ever considering a treatment strategy like this. He also looked at how a clinician has to ensure that the therapeutic relationship is of the right quality and depth. It has to be the right type of relationship to handle this type of treatment. And he also looked at the client characteristics themselves. There are client characteristics that are important to keep in mind here. For example, Stephen was highly directable, and not everybody with OCD would be. Like so many of the counseling techniques inspired by strategic therapy, this one is a very interesting approach that's also very challenging to apply ethically. I think the highest and best use of a case study like this is not about learning the technique so that one can actually apply it, but rather about learning how people with OCD may react in various situations, how they may respond to setting goals and being congratulated when they achieve those goals, and how they may learn to break themselves away from compulsive behavior. So always with strategic therapy, you're going to run into this tricky territory with ethics, right? I've talked about this before in other videos, and I think this case study is really no exception. Again, there's a lot to learn here, but we have to be really careful when trying to apply something like this. I always find these case studies looking at strategic therapy to be fascinating. They're a good reminder about what's possible in therapy, and also a good reminder about how we have to be careful in terms of the ethics. I know whenever I talk about disorders like OCD, there will be a variety of opinions. Please put any opinions and thoughts in the comments section. They always generate really interesting dialogue. As always, I hope you found this case study on OCD to be interesting. Thanks for watching.